Management of inguinal hernia. So inguinal hernia is a protrusion of abdominal contents into the inguinal canal through which the abdominal wall defects. Approximately 4.5 million people in the United States have inguinal hernia, and around 500,000 new inguinal hernias are diagnosed annually. Lifetime risk of inguinal hernia is about 25% and 2% in females. The inguinal hernia can affect all ages, but the risk for one increases with age. Approximately 20% of the hernias are bilateral and seen in both right and left side. In the children, the incidence of the inguinal hernia ranges from 0.8 to 4.5%. It is 10 times as common in boys as in girls and is more common in infants born before 32 weeks gestation and infants weighing less than 1,000 grams at birth. A direct inguinal hernia protrudes through the inguinal floor defined by the Hasselbalch's triangle, the pubic tubercle, the lateral border of the rectus, and the inguinal ligament, and accounts for one-third of the all inguinal hernias. An indirect inguinal hernia protrudes through the internal inguinal ring and may descend through the inguinal canal and accounts for about two-thirds of inguinal hernias. The direct hernias typically develop only in the adulthood and is more likely to recur than the indirect hernias, and it is because of the defective posterior wall. If the hernia is severe enough to restrict the blood supply of intestine, it is termed as strangulated hernia, and it's a surgical emergency and immediate corrective surgery is necessary. Most hernias, however, are less dangerous. Patient present them for a long time and is often performed to correct the defect. The symptoms include the abdominal pain and a lump in the groin, and which is easily palpated with a cuff. Also, cuff impulse is positive; they are reducible. Some inguinal hernias, however, are asymptomatic and only detected by the palpation or a cuff impulse or a cuff reflex is seen. If the patient has previous surgery or in the recurrent hernia, you can see the surgical scars as well. Or the patient has obesity or chronic cough or defect in the abdominal wall, then there are high chances of having recurrent abdominal hernias or inguinal hernia. So the surgical repair is the definitive management. There is no role of medical management. It is most commonly performed with general surgical procedures. About 70,000 surgical repairs were performed in 2003. Most repairs are performed on outpatient basis. The primary goal of the surgery are to repair the hernias, minimize the chances of recurrence, return the patient to normal activity quickly, and improve the quality of life and minimize the post-surgical discomfort and adverse effects of surgery. There are various types of repair over the period of years. The surgery has evolved from the open techniques to the laparoscopic techniques, minimally invasive techniques. So the surgical repairs fall into three main categories. The open repair without a mesh, so we just repair the facial layers. Open repair with a mesh, and a laparoscopic repair with mesh. There are several techniques when you lay the mesh. It's onlay, inlay, sublay with the abdominal defects. So there the nearly universal adaptation of mesh, except in the pediatric cases, means that it is more relevant question about the hernia repair involves various mesh procedures. So Kugel's patch repair is an oval-shaped patch which is held open by a memory recoil ring and inserted behind the hernia defect and held in place with a single suture. Liechtenstein technique is a tension-free open repair wherein the mesh is sutured in front of the hernia defect anteriorly. Mesh plug technique is a pre-shaped mesh plug. It is introduced into the hernia weakness during the surgery, and a place of flat mesh is put on the top of the hernia. The open preperitoneal mesh technique, a tension-free repair within the mesh, is sutured posteriorly. Prolene hernia system is a one-piece mesh device constructed on the onlay patch connected to the circular underlay patch by a mesh cylinder. So a reed reverse repair is a tension-free repair wherein the mesh is placed just over the peritoneum. There is a sort of sublay technique. Stupa technique is a large polyester mesh is interposed in the peritoneal connective tissue between the peritoneum and the transversalis fascia to prevent the visceral sac extension through the myopectinate orifice. Turberco technique, a hernia repair defect procedure that involves placing a single pre-shaped mesh without using sutures. Laparoscopic mesh-based repair procedures for inguinal hernia. The intraperitoneal onlay mesh technique is a mesh placed under the hernia defect intra-abdominally to circumvent the groin dissection. Totally extraperitoneal technique, the peritoneal cavity is not entered and the mesh is used to cover the hernia from outside and the preperitoneal space. Transabdominal preperitoneal technique is a laparoscopic repair procedure wherein the surgeon enters the peritoneal cavity, incises the peritoneum, and enters the preperitoneal space and places the mesh over the hernia, and peritoneum is then sutured and tacked closed. So it's sort of sublay technique. Surgical mesh products are typically made from the polypropylene or polyester. So we can say it's a Prolene mesh or a polyester mesh. The other available materials are polytetrafluoroethylene, polyglycan, polyglycolic acid, Vicryl, or polyamide. Seven important properties of mesh are withstand the physiological stresses over the time, confirms into the abdominal wall, mimics normal tissue healing, resist the formation of bowel adhesions and erosions into the visceral structures, and does not include the allergic reaction or foreign body reaction, and resist infection and is non-carcinogenic. So the clinical questions are: what is the comparative effectiveness of laparoscopic versus open repairs, different types of repairs for pediatric population, surgery versus watchful waiting in the adults with a pain-free, minimally symptomatic inguinal hernia, different types of open surgery, different types of laparoscopic surgery, different mesh repairs, different mesh fixation approaches, and is there any association between the surgical experience and inguinal hernia recurrence? So the outcome and adverse effects are important. Outcomes are hernia recurrence, hospital-related length of stay, return to the daily activities, quality of life, return to work, patient satisfaction with the cosmosis, patient satisfaction with the pain, short and long-term effects after surgery, intermediate pain relief, and a long-term pain after surgery. Adverse effect: uh, infection, seroma formation, foreign body reaction, small bowel obstruction, perforation or subacute obstruction, hematoma or seroma formation, epigastric vessel injuries, which is rare, urinary retention, which is quite common in the immediate postoperative period, and damage to the spermatic cord. So the surgical repairs of the bilateral hernia, the patient with bilateral hernias return to work about 2 weeks sooner after laparoscopic uh, TAP or TEP repair versus the open Liechtenstein or Stupa repair. The evidence of was inconclusive for all other outcomes, and the adverse effects of laparoscopic versus open repair of the bilateral hernias. Mesh repair may improve a patient's overall health status at 12 months more than watchful waiting, and there is not enough information to know is there any difference between the adverse. So, concluding the adult hernia repair, the laparoscopic repair of the inguinal hernia is associated with faster recovery, lesser risk of long-term pain, low risk of another hernia recurrence after the previous surgery, and open hernia repair may be associated with fewer internal injuries, lower recurrence rate in the context of primary inguinal hernia. So the conclusion is research found most of the mesh or fixation methods are to be equivalent in their effectiveness and the risk of adverse effect with only a small exception and variation. So there are a few things which we don't know and we need to have more knowledge in those fields. So one of the most important thing is how the surgeon experience influences the surgical outcome, such as recurrence of pain, especially when surgeon who is doing open and laparoscopic surgery compared to the surgeon who are only trained on the laparoscopic surgery and they do minimal of the open surgery. Comparative effectiveness and adverse effect of the laparoscopic repair versus watchful waiting for the pain-free, minimally symptomatic inguinal hernias in adults. The comparative effectiveness of adverse effect for contralateral exploration and repair versus watchful waiting in the pediatric population. More evidence of the several outcomes related to the comparison of a mesh product and fixation method, including the recurrence rates, perception of the foreign body, long-term pain, and infections. The clarification in future studies of whether the population includes the emergent as well as the effective surgeries and whether or not the findings apply equally to both populations. So the issues is one has to discuss with the patient, one has to come up all the problems, and there has to be a consensus between the patient and the surgeon. And the issues are if the patient or watchful waiting is the right decision for the pain-free or minimally symptomatic inguinal hernia, how to choose between the open or laparoscopic surgery if the option is available, and what to expect from open or laparoscopic repair as far as the outcome and adverse effect, including the risk of long-term chronic pain, and what to do if the hernia recurs, and how to keep an eye on the recurrence. Thank you.